It's a pleasure to be speaking to you today. My thanks to the organisers, and apologies for being unable to be with you in person at this excellent meeting that's been put together by the organisers. So today, my talk is perhaps a little bit more future-looking than some of the other ones. Perhaps some of it will be a little less immediately practically applicable compared to Nikos's excellent presentation. And we're going to talk about where treatments in premature ovarian insufficiency largely might be going. So these are my disclosures. The only one I think of relevance is as I was chair of the ESRE POI guideline development group that published now in 2006, and actually the work is now just starting to revisit that, and in a couple of years' time we'll be able to produce an updated guideline on this subject. So what I'm going to talk about today is a little bit of a background, and I hope it's not too obvious, some of the background to the etiology of POI, and particularly bring in new concepts here into some of the novel genetics that are really an exciting area in this field at the moment. We're going to touch briefly on current management, but only just really, of course, as a background to the second half of my talk, which is really going to be where future treatments might be going in the management of fertility in women with premature ovarian insufficiency. So we have, of course, a very clear understanding that the basis for this is that the ovary develops before birth. Primordial germ cells migrate to the ovary. They undergo proliferation, followed by entry into meiosis. And it's very important that that happens, we recognize that that happens at that time. And then meiosis arrests in metaphase 1. And the primordial follicles are formed. And on the left here, you see an image from a fetal ovary of just 17 weeks gestation, where you have a newly formed pair of primordial follicles. And of course, that follicle may well sit there for decades before it's called upon to produce both the fertility for that individual woman and, of course, from the surrounding cells, her endocrine milieu. And of course, thereafter, we then are familiar with this decline in the number of follicles within the ovary across age. And this is data from my colleagues, Hamish Wallace and Tom Kelsey, who derived this mathematical model. And you can see this steady decline. And of course, this highlights that not only are we considering perhaps in the etiology factors that might affect the formation of primordial follicles, but a lifetime of lived experience of that ovary as to how those follicles are then subsequently used up. And it's also important to note, relating some of the things I'm going to say later on, is that, of course, the menopause is not associated with an absence of primordial follicles, just very few, and not enough to steadily supply that conveyor belt that is needed then to supply the number of larger antral follicles that will underline the small number of follicles that are needed to produce regular menstrual cycles. And it's this lack of the sort of the background number that is going to prevent ongoing menstruation in later life. So we have, of course, the ESRE guideline, as I mentioned, good evidence-based guidance on this. This paper here is a review on HRT that was derived from that. And more recently, this paper at the bottom, led by Nick Panay from the International Menopause Society, I'd recommend as an excellent and very readable update in the diagnosis, etiology, and treatment of this condition. So if you want a refresher on best clinical practice, I would highly recommend that open access paper. So let's just think about some of the concepts that are included in this then, the diagnosis. Well, of course, we have age of under 40 years, which is 2 standard deviations below the average age. And a lot of this is the reason I'm showing you this is it's old hat, but of course it's to highlight that a lot of it is relatively arbitrary. So how long the duration of amenorrhea should be before making a diagnosis is, of course, arbitrary. And the longer you make it, the more robust the diagnosis will be, but of course, it'll be increasingly inconvenient, both for starting treatment and for the patient's management. And then we have this issue of an elevated FSH over 25, not completely arbitrary, because that was actually based on being 2 standard deviations above the mid-cycle peak in FSH that occurs at the same time as the LH peak. But of course, you'll be familiar that other guidelines suggest higher values, sometimes 40, but in clinical practice, you will see a lot of women whose FSH values are not as high as 40, for example, but clearly have POI. So we felt that 25 was a useful guidance. But on 2 occasions, more than 4 weeks apart, again, these are debatable and not robustly evidence-based. Of course, one of the hormones that we've talked about already a little bit this morning that is not featured in that is sort of crying out to be considered is anti-Müllerian hormone, and whether this is a useful diagnostic test in POI. And it remains absent from current guidelines. And in fact, we've recently been conducting a review of the literature on this, and what that clearly shows is really the lack of robust diagnostic testing studies that have been used to explore this. I think certainly it will have a place. I'm sure in everyone's practices already has a place, because we know, for example, from this study that my colleague Raymond Lee in Hong Kong published now a decade ago, you can see how low AMH levels are in women with POI compared to control. And actually, particularly the point of this publication was to contrast with other causes of oligoamenorrhea, notably PCOS, type 1, hypergonadotrophic hypergonadism, and hyperprolactinemia, where they're generally normal but with a range. But you'll see that although AMH levels are generally low in POI, they're not absolutely undetectable in all women. There's quite a range, in fact. But I'm sure it will become part of this. It will be particularly useful in those women who are referred, and you often see them when they've been seen by other colleagues in other specialties, perhaps, or in primary care, where someone has had amenorrhea and their periods have come back for a few months, and there's the test, the FSH level is high once and then normal, and what's going on? And of course, the AMH level will be robustly low in that circumstance. The one caveat is that occasionally it can actually be relatively normal in women with particularly autoimmune causes of POI. So that's an important consideration as well. So let's just think a little bit about what are the causes, and particularly where the causes might be going in the future is the reason to go over this sort of basic background for you. So of course, we have a lot of interest in the cancer-related aspects of POI and surgery-related, particularly to endometriosis, and of course, whether fertility preservation approaches can be best used for those women at risk of POI. We have long-standing knowledge of a genetic basis. Something like 30% of patients have an affected relative, and this is really where the key growth area is at the moment, with identifying both monogenic causes of POI, and there is more and more literature coming out with these, but they still at the moment make up a relatively infrequent number of diagnosable causes. We have the chromosomal ones here, and I think the point I want to just remind you all of is the importance of the multimorbidity in these patients. And we have the autoimmune, again, with potentially significant other risks to that woman's health, particularly in the presence of adrenal antibodies, putting her at risk of Addison's disease. I'm not going to talk about infectious conditions. That's perhaps ironic at this time of this current pandemic and why I'm not with you in person. And we're going to talk a little bit about idiopathic, because I think this is another growth area where we're understanding why so many of our patients do have apparently idiopathic, and I'll come back to that in a minute. So in our current practice, certainly in the UK, the one gene that we do test for is mutations in the FMR1 gene, which causes Fragile X syndrome. And this is, of course, a trinucleotide repeat, a triplet repeat pathology. You have CGG repeats in the 5' UTR of this gene, which normally is less than 44, can expand to over 200. And under those circumstances, that will lead to full-blown Fragile X syndrome without the RNA or indeed the protein being expressed. But the interesting area for us today, of course, is these pre-mutations where you have a degree of expansion, potentially an excess of RNA, and there are interesting biological theories about how this excess RNA is toxic in itself, because it's a binding, it effectively traps other RNAs, and perhaps normal or reduced Fragile X protein being produced in these cells. So there's an interesting work going on as to what is the cellular pathology in this condition. And of course, we're not really interested in this diagnosis for the patient sitting there in front of us. It's particularly the implications for her relatives who may have either a risk of POI or perhaps even more importantly, a risk of an affected child where they're carrying without known to themselves a child who could have a full expansion. What's really interesting in this area at the moment is where the genetics are going. And this is a paper that was published I'm sorry, the reference seems to have gone off the screen, but it was published just last year, looking at an enormous analysis of over 200,000 women, looking at the genetics of age at natural menopause and bringing in premature ovarian insufficiency as well, but largely focused on age at natural menopause. And they identified over some 290 genes that all had an impact on age at natural menopause. So a phenomenal amount of information. And they were able to put that information together to get what they called a genetic score. And you can see here the relationship between this genetic score and age at menopause with essentially a fairly linear relationship. So the bigger the score, the bigger the relationship between a very negative score really and a very positive score for the whole range from POI right through to relatively late natural menopause. And you can see another way of addressing essentially the same thing is looking at age of early menopause, less than 45. You can see this very clear relationship with women with this higher genetic score having this significantly increased risk of an early menopause. And when we look at that here in the right-hand graph for POI specifically, it's similar. And wider error bars, because there were fewer women involved in this, the majority of women were progressively older with their age of menopause, but you can see that clearly is a relationship here. And I think what's important in this general concept is it highlights that this is a continuum and that many of the women we will see with not the dramatic, perhaps primary amenorrhea, single gene related POI etiologies, but a lot of our patients will be on this spectrum. And this is a spectrum that goes from POI right through to late menopause. And really highlights that this is just, as I say, essentially a spectrum of presentation for our patients. What is interesting about that study as well is, let's just go back one, is that many of the genes that they identified as being relevant to this were related to DNA damage repair. And that is increasingly a hot topic in this whole field of ovarian aging. And indeed, a study just done a few years ago from many of the same investigators actually identified this in a preliminary analysis where they identified DNA repair as being a key aspect of reproductive aging and age at menopause. And indeed, one of the genes they bring out of that is one that I'm sure you'll all be familiar with as a DNA repair gene, which is the BRCA1 gene, and its obvious important mutations relevant to cancer predispositions. And this figure here just shows a whole range of different pathways that are involved in genes regulating age at menopause. And I want to particularly highlight this novel information that we have on how important DNA repair is in the oocyte to cause, or in the follicle, I should say, because we don't necessarily specifically ally it to the oocyte at the age at when the ovary ceases to function. If we look at the BRCA1 gene itself, actually there's been significant interest over a number of years in how women with that mutation, how their ovaries are functioning. And there's been a lot of work, number of studies that looked at the AMH levels in these women to see whether they're lower and that might predispose to POI. And this is one study from Australia that I was involved in, where you can see AMH levels were measured in a number of women with BRCA1 carriers over the reproductive lifespan, and their AMH levels were on average 25% lower, and they had a significantly increased odds ratio for being in the lowest quartile for their age. And this seems to be particularly a problem with BRCA1 rather than BRCA2. And Kutler-Cokte in New York has done a lot of work in this, particularly in women coming forward for ovarian stimulation, for fertility preservation, or for IVF itself. And indeed has also highlighted this poorer response. So women with BRCA mutations obtain fewer eggs than age-matched controls. And you can see this very dramatic increase in the odds ratio for a poor response, shown graphically here on the right, with about a 38-fold increased risk of a poor response compared to controls. So these ovaries have fewer oocytes and they respond more poorly because of this mutation in this DNA binding protein, DNA repair gene. So what can we do for our patients who come with this problem? Well, you'll be familiar with the established things. Of course, we talk about oocyte donation and we talk about hormone replacement. Those are the key bedrocks of current therapy. And I'm going to go on to talk about where this might be going in the future, some really exciting developments in this. Oocyte donation has, of course, been around for a very long time. This is a paper actually from 1984, which I think is the first to report this, although actually it was about embryo donation rather than oocyte donation, but it reported successful pregnancy in this group from Melbourne for a woman with primary ovarian failure, as it was then caused. And of course, now we recognize this as an absolutely established, and this is a quote from the ESRA guideline saying, highlighting this as robust evidence, this is an established option for our patients. Of course, there is a background pregnancy rate, and I think that one of the things to remember when we're talking about new therapies here in this is the need for these studies to be robustly controlled, because this has been a source of a lot of problems, a lot of misrepresentation perhaps in the past. And perhaps the best overall data on that is some old studies, perhaps going back actually to the mid-90s, discussing or demonstrating that in a properly controlled series, the background pregnancy rate is about 2.5%, sometimes as long as 8 years after diagnosis, although mostly within the initial years. But it can be really remarkably late in a few people and a few women. The important other aspect of that is shown by another very old but excellent review, which looked at the reported prevalence of this background pregnancy rate according to the design of the study. And they demonstrated that in observational studies, there was about a 5% pregnancy rate. In uncontrolled studies, it was actually 18 getting on for 20%, but in the properly controlled studies, it was this low rate of 2 to 3%. And of course, that is really important information, both for our parents' information as well as for the designing studies properly to really not give inflated pregnancy rates. So it can happen mostly in initial years. And of course, there is a need for contraception here in women who definitely do not want to fall pregnant at that time. So, and the final part of my talk, I want to talk about 4 areas of where treatment might be going for particular types of these patients. And one would be, one area is whether we can rescue any remaining oocytes from the growing follicles that you might well see on a scan when you make that diagnosis, whether we can activate either non-growing or the very early stages of follicle development and get eggs, mature eggs from there, whether we can have some sort of regeneration of the ovary. You'll be familiar with the concept that has been advocated of oogonal stem cells, perhaps through that or perhaps through some other unknown mechanisms. Can we regenerate the ovary and make it last a little bit longer? And then finally, to take the other view, can we just bypass the whole thing and just make eggs from scratch? So let's just talk a little bit about each of those 4 aspects. So rescuing eggs from that are already grown from mature follicles. Well, this is where in vitro maturation comes in. And this is a case report from Michael Grinberg and colleagues in Paris describing this in a woman with autoimmune POI. So a classical clinical presentation, amenorrhea, high FSH, lots of autoantibodies, AMH low but not undetectable, but scan normal looking follicles, actually really quite a high antral follicle count, you might think, for a 36-year-old. And they tried stimulating her ovaries with exogenous FSH, and of course that didn't work given these FSH levels, but they had 2 cycles. She had 2 cycles of IVM. They obtained 12 eggs, 8 embryos cryopreserved from that, and subsequently 2 were transferred, and she has gone on to have twins from that. So a case report, but a demonstration that this is a way forward for those patients that you will see where the ovary looks remarkably good and is discordant to the endocrinology. Of course, setting this up in an IVF lab is not trivial. This is a different concept to normal IVF, but it's certainly possible. And there are increasing case reports for this. And those of you who are members or follow the work of the Oncofertility Consortium, led by Teresa Woodruff, may have seen an email in the last few days advertising that Michel de Vos from Belgium is going to be giving what will be, I'm sure, a masterclass webinar on IVM in the context of fertility preservation I think in late February. What about this follicle activation? Well, this really kicked off with this excellent paper from Japanese colleagues looking at whether you could remove the ovary from women with ovarian failure, with the POI. You could chop it up, essentially. They disrupted it, which was largely attributed to disruption of the hippo signaling pathway, which regulates follicle activation. They also gave it some chemical treatment. So this is with AKT stimulators acting on the PI3 kinase pathway that is such an absolutely critical regulator within the oocyte of follicle activation. So with that combination of ex vivo treatments, the tissue was then replaced, and they were able in some women to obtain mature eggs, embryos, and indeed children, offspring in some of those women. And this was, therefore, it has these two key features. This was a surgical procedure plus a chemical treatment. And they very sensibly also looked at the histology of these ovaries and demonstrated that actually when they saw more follicles, then it was more likely to be successful. And when they didn't see any follicles, it never was. So this has been a really intriguing way forward, and there have been attempts to try and do this more robustly. Perhaps one of the ways in which this has been done is this study from colleagues in Copenhagen, where you'll notice not women with POI, but women with diminished ovarian reserve, as they defined it. And their interesting approach here was to do a laparoscopy, take biopsies of one ovary, randomly right and left, hence a degree of an RCT in this. And the other ovary therefore acted as the control. And what they did is they took the tissue out. It was essentially a little bit fragmented, and then they put it straight back in at the same surgical procedure. And then they observed how that patient's ovaries functioned, and particularly comparing, as I say, the operated and the non-operated ovary. But it didn't seem to have any detectable effect on the number of follicles, and when they underwent IVF and ICSI some weeks later, it didn't seem to have any detectable benefit. But you'll notice, and this harks back to my slide a few slides ago about the background pregnancy rate in such patients, you can see how very many of these women were able to have a pregnancy subsequently, but they weren't able to relate that at all to this surgical procedure. But I think, as I say, it just highlights the importance of a significant background rate of pregnancy in this type of patient with a poor ovarian reserve. Third approach, what about regeneration of the ovary? That would be such an exciting thing to be able to do, to be able to offer our patients a way of saying, we're going to just get your ovary working again. And that is an area of such a lot of effort and work at the moment in a number of labs. And I want to show you a couple of slides from one of the leaders in this field, Sonia Jerez in Spain, who's done some fantastic work. This is mostly rodent work, but there's just a smidgen of human work I'm going to show you as well. So this is a model of chemotherapy-induced premature ovarian insufficiency or ovarian damage that she uses, 2 different doses, one 10 times higher than the other. And what they did in this study was they took either peripheral blood cells as a sort of serum control or bone marrow stem cells as their key treatment that they wanted to investigate, and whether infusing these animals and treating these ovaries with these stem cells could regenerate follicles within the ovary. And this is one of their key findings from their study. So you can see in the lower dose chemotherapy, the animals that received the bone marrow derived stem cells show more oocytes when they subsequently underwent ovarian stimulation, not seen in the peripheral blood treatment. And of course, these are the controls. They didn't see that in the higher dose therapy. And actually across the literature in this whole field, there's a clear evidence that the dose of damage to the ovaries is important. And if you really, really damage the ovaries and obliterate them with high dose therapy, lots of studies have shown a failure to respond whereas there is a response to a more modest treatment. So I think there's some definite truth in those observations. And this is their data on litter size, which is, sorry, the colors don't match, but you can see here in the blue, this is the good treatment group, where you can see they went on to have litters, up to 3 sets of litters, whereas in the controls, in the red, you can see there's decline, and they had none in the third, but in the peripheral blood, they also did see some in the third. So a preliminary data, but just a suggestion that this might be some activation going on here. They've gone on to refine that, and there's a study where they tried to use granulocyte colony stimulating factor just to activate the bone marrow effectively, and to then release factors into the plasma that could then be used in this situation. And in these animals, which the same POI induced from the chemotherapy, you can see they had more primordial follicles compared to the controls with this GCSF activation. And intriguingly, they had some human ovarian tissue they were able to treat with this as well. And you can see there's a suggestion of more primordial follicles, perhaps, although very variable, more secondary follicles, and indeed a bit more cellular proliferation going on in the tissue, and perhaps a small increase in microvessel density as well. So some intriguing preliminary studies here, but certainly some very exciting possibilities of where this might be going in the future in a range of different situations. And of course, there'll be some conditions which will be amenable. Some etiologies will be amenable to this type of therapy. Others, perhaps the more specific monogenic ones, probably will not. Finally, let's just think about making eggs from scratch, complete in vitro gametogenesis. And this is some work again from Japan, where this is an image from this group's most recent paper, from Hayashi's most recent paper, but a phenomenal series of papers leading up to this work, actually. So the essence of their approach has been that they've derived methods for obtaining what they call primordial germ cell-like cells, bit of a mouthful, from embryonic stem cells, mouse embryonic stem cells. And in previous studies, what they've done is taken these primitive germ cells and mixed them with ovarian somatic cells from developing mouse ovaries where the oocytes had been removed, so endogenous somatic cells, and reconstituted an ovary-like organoid, essentially, and gone on and demonstrated that could restore fertility in sterilized animals. And in this most recent paper, they've taken it to the next step, which is to derive all the cells that you need from these embryonic stem cells. So as well as these germ cells, they also demonstrate the production of follicle somatic cells, the precursors of the granulosa cells. And they were then able to mix these together with no other natural cells and reconstitute of an ovary, which then developed follicles, fertile offspring from it. And you can see here in this remarkable picture, these are the COCs, oocytes, cumulus cells, all derived from embryonic stem cells and fertile. Now, there's, of course, a whole lot of issues here regarding potentially the reproducibility and the safety of this for human use, but you can see that this is a field that's really advancing quite rapidly. And it's certainly not beyond the stretch of imagination to think that this might be applicable to our patients in the not too distant future. So in conclusion, I hope I've shared with you some of the really exciting work in this, particularly our novel understanding of the genetic basis of the reproductive lifespan in many of our patients, and how DNA repair enzymes are absolutely critical for this. And it also highlights how for many of our patients, their POI is actually a spectrum that blends with other genetic factors and other genetic score, essentially, as was proposed in this paper, that determine their age of menopause. And they've just got a very high score, and that's given them the POI, separate from other women who will have specific monogenic mutations. And I hope I've given you something interesting to think about regarding potential novel therapeutic approaches to the restoration of fertility in our patients. Things that are here now: IVM, potentially surgical fibrosis follicle activation, and more futuristically, regeneration or indeed in vitro gametogenesis. So this, of course, is a lot of very exciting work, but it really, we shouldn't lose sight of the fact that for our patients, for many of them, their fertility is absolutely front and center, but over their own lifespan, there are a whole range of other aspects of their health that we also need to address and recognize, bone health, cardiovascular, all these whole list of things leading to quality of life and indeed life expectancy in our patients. So thank you very much for your attention, and I'm delighted to join in a discussion after this. Thank you.
Thank you very much, Professor Anderson. An exciting area, but also a very sad one, and many times hard to handle when you're face-to-face with the patient, of course. So can we open the floor for questions, please? Anybody wants to ask a question from the floor? Professor Fertility, please.
Thank you for the very updated and nice presentation. As usual, I have one comment and one question. The comment is on the paper of Grimberg and Christopher Zeifer from Paris, which you referred as IVM in a POF patient. I think that patient had simply FSH receptor defect. So that patient, as you have seen, she had a very good antral follicle count. This patient had an elevated FSH, so simply that patient didn't respond to FSH. So I don't think that was a POF patient. My question is, obviously, we are looking more and more towards DNA cell repair damage mechanism, which you clearly demonstrated is linked to also cancer. This is also why we see with patients undergoing IVF long-term, they have much higher risk of developing cancer later. But is it only a reduced ovarian reserve that would be pointing towards that issue? Because from our clinical experience, we see also patients with repetitive miscarriages. We would say unexplained repetitive miscarriages with more or less a normal ovarian reserve. Could that be also an entity which we should be also cautious long-term, possibly also leading to cancer with that particular patient? Since most of these patients, the cause of miscarriage is linked to the genetics. And could it be that because those patients have DNA cell repair damage mechanism, which is leading to these repetitive miscarriages, despite the fact that they still have more or less a normal ovarian reserve independent of age?
Yeah, that's a very interesting concept there. And I think it may well be there's some convergence of this work that in the future, but I think at the moment, so clear links between all those various strands that you brought in there with potentially links to their subsequent cancer risk, as you mentioned, or their age of menopause, that really remains to be established. It would be nice to have a unifying hypothesis here, wouldn't it? And I think that actually one of the things that this work on the DNA damage repair pathways does bring is a much more unified hypothesis to our understanding of oocyte quality, and that, of course, will absolutely impact on miscarriage rate as well as to reproductive lifespan. So yeah, absolutely, these things are coming together. Quite where they might go in therapy for those patients, I think, is a very intriguing question. I don't know if you want to comment on that, but that certainly would, of course, be the next stage, because it's one thing working out for a patient why things are going wrong. It's a very different thing being able to help them to improve on the situation.
Thank you. A second question here.
Excellent presentation, Richard. I really enjoyed it. Juan García Velasco from Spain. Just as a co-author of the ESRE guidelines, do you have any practical recommendations regarding ovarian tissue fragmentation? I mean, could this be an option prior to egg donation in women, I don't know, who have POI under 35 or under 40? Should it be done in the first year or in the first couple of years after POI has been diagnosed? Any suggestions?
I think at the moment, Juan, I would not be recommending that patients have that type of surgical procedure at the moment. You know, when you're taking ovarian tissue out and fragmenting it and putting it back, there is a significant risk, I think, that you might be doing harm as well as potentially good in terms of activating follicles. So I think in the absence of more robust evidence that on average you are doing good, I think at the moment that remains very much in the realm of clinical research rather than clinical practice. The other aspect of the paper that I showed you was the chemical activation. And this is an area that we've actually been investigating ourselves in the lab as well. And while undoubtedly these drugs that induce follicle activation, they do that through the PI3 kinase pathway, actually what we are finding is that the quality of those follicles is often extremely compromised. So maybe there is a big flush of activity, but it may be relatively inefficient with a majority of those follicles not having sufficient quality to then complete maturation and be fertilizable.
Thank you. Further questions, please.
So first of all, let me congratulate you for your excellent presentation. I think that the main issue about the premature ovarian insufficiency is to find a way to predict the risk to become an insufficient patient in the future. I would like to know if you have some experience about the use of the ovarian reserve markers. For instance, a young woman with really reduced ovarian reserve, but with normal menses, with normal gonadotropin value, are at increased risk to develop premature ovarian insufficiency. Because I think that if we found a way to predict the risk to develop this kind of syndrome, maybe we could plan a sort of fertility preservation, as we plan, for instance, for oncological patients, in which we collect oocyte before the chemotherapy. And after that, I'm really curious about this relationship with the DNA repair issue, because I know that this pathway is widely recognized for oncological disorders. Is there a risk or a correlation between premature ovarian insufficiency and, for instance, a history of cancer or other cancer issue, apart from, obviously, the exposure to chemotherapy?
Yeah, thank you very much. A couple of very interesting questions there. So regarding the first one, then you'll be aware that, of course, there's been a lot of work in substantial cohorts of women seeing whether particularly a low AMH predicts age at menopause. Remarkably, there's very little published on that, in fact, in terms of prediction of POI. The majority of the literature, and which of course is why what the normal situation is for the vast majority of women, is about predicting variation in the age of a more normal age of menopause. And clearly, AMH does have some predictive role there, but actually not very good. The prediction is really pretty poor, except, as you, I think, mentioned, at these extremes, where women with very low AMH do have a significantly increased risk of POI. And I think that is certainly something that will be coming in more widely, and I'm sure many of you are already using it. We've certainly seen cases ourselves where patients have, for example, been attending the general endocrinologist and been found to have Addison's disease with autoantibodies and a very low AMH. And those patients, I would certainly agree, are excellent candidates for potentially intervention and fertility preservation before they show any actual established features of POI. So I think there certainly is grounds for identifying that. I think it sort of becomes a grey area when you start looking at the wider population, because that's where, as I say, the prediction becomes really pretty modest. Your second question, I think, was about DNA repair and cancer predisposition. Clearly, there are one or two genes that clearly are very important in that, and I highlighted the BRCA1 and BRCA2 mutation genes there. Many of these other ones are associated with perhaps rarer cancer syndromes, but the great majority of them, as I understand it, and I'm certainly not an oncologist, I don't think they are so widely established in that regard. But it may be that, I don't think they are at the moment.
Thank you. Further questions from the floor? There were 3 questions online. One was already answered. It's the lady with the very low AMH incidentally found at the time of a routine control, so encourage the 26-year-old to cryopreserve, as Professor Anderson said. Do you see light at the end of the tunnel in patients with POF and stem cell treatment in the future? I don't know if you want to say a word there, please.
Yeah. Actually, I think I do. It's going to be a long time coming, but I think there will be something one day where a very exciting work that I showed you by Sonia Hareth and colleagues, and there's a lot of other work around that's still very controversial, but I suspect that there is some grain of truth in there that we haven't got to the bottom of it, and there's more to understanding these early events in the ovary than we currently understand at the moment. And maybe there are a population of dormant stem cells in the ovary that can be reactivated under certain circumstances. It's going to be a very specific set of circumstances probably, but I suspect that one day this will come to pass.
Thank you. I have two more questions. They're reasonably short, but they relate to very clear clinical scenarios, which I think the audience will benefit from an answer. So the first one is a patient that has been diagnosed with Fragile X syndrome. Do you recommend pregnancy with her own oocytes, providing that she has some at all, regarding the risk of intellectual insufficiency in the male offspring? So what do you do with this patient?
Yeah, that's an excellent question. It's not one that I've personally been faced with, but we certainly have been in women with incipient POI, where we do rarely find a Fragile X mutation. Then that would be a consideration. Therefore, perhaps pre-implantation genetic testing, wouldn't it? I think that would be the way forward there, because it is an important cause of significant intellectual disability in the offspring of those patients. So I think that would be the main consideration. Of course, you're into this double-edged sword of, which is the case for so many of these patients, that actually the question is getting enough eggs to be able to realistically do that, and that poses very significant practical problems for these patients.
True, and also finding an embryo that doesn't have the mutation in that. Thank you.
Yeah, they often seem to have far more affected embryos than you think the genetics would predict somehow.
Yes, and the next one is very topical and very important, considering that approximately 1 in 500 adults now are survivors of childhood cancer. The question says, for long-term childhood cancer survivors with resumption of ovarian function, would you recommend serial OR tests or fertility preservation due to risk of POI?
Yeah, so that's interesting. We've actually just published a paper in Fertility and Sterility just in the last few weeks, looking at fertility of cancer survivors. Surprisingly, looking at women who are able to have a pregnancy after cancer, their reproductive or their fertile lifespan was remarkably preserved. They were able to go on having children for as long, or nearly as long, as their age-matched controls, which was really unexpected. But I think that nevertheless, there will be individuals who have had significantly damaging therapy who will only have a narrow window of fertility. And so I think there certainly is a value in having that discussion, that analysis with patients who have faced significant toxic therapies to see if we can identify whether there is grounds for concern or whether it does appear that they can be reassured that their ovaries seem to be functioning relatively normally. And just to remind you, that the established literature in the field shows that the chances of parenthood in female and male cancer survivors in childhood is actually extremely good.
There must be a protective effect in the ovary, obviously, in an unstimulated ovary before menarche, yes. So Professor Anderson, thank you so much for this very exciting session. A lot of immediately clinically applicable points you've given us. Thank you.